code. Yes. So today we'll be talking about basically iron therapy and vitamin B12 and folate therapy. And you have already had lectures on iron deficiency anemia and megaloblastic anemia. So we will quickly refresh the knowledge that you have on the metabolism of each of these vitamins and talk about pharmacological treatment. Okay, so during the lecture, we'll discuss a little bit about the principles of therapy, discuss about iron metabolism, which I assume that you have learned already, and a little bit about vitamin B12 and folate metabolism, and look at treatment with iron, vitamin B12, and folate, looking at the indications, the different preparations available, and the side effects, cautions, and contraindications. And finally, we will look at the use of erythropoietin in the treatment of anemia and the use of iron chelators in iron overload. Right, so this is just to quickly refresh your knowledge. Can you take 30 seconds and try and fill in the blanks in this statement? Yes, Melanie, oh. If you all have any questions, you can ask me at any time as well. Okay, so let's try and complete this together. Normal body iron content in a healthy adult is usually how much of iron is present?
.5 grams.
Yes, so it's usually 3 to 4 grams that is present as hemoglobin, which is the primary sort of amount that is that's 2 to 2.5, right? And then you have the iron contained in other proteins like myoglobin, cytochromes, and catalases, which is about 300 to 400 milligrams. And then you have the plasma bound iron, the iron in plasma, which is bound to transferrin, which is about 3 to 4 milligrams. And then you have the iron that is stored in the liver or in the other macrophages as ferritin or hemosiderin. And it's usually the iron stores are much higher in a man, which accounts to about 1 gram, but in women usually have lesser amount of iron stored in the body, and it depends on whether they are menstruating, whether they are pregnant, and whether uh, they are lactating, and the iron intake as well. Right? So this is a very brief, very easy MCQ. Can you try and answer this as well? Essentially, all circulating iron is bound to transferrin. True or false?
False.
Others? It's most of the circulating iron is bound, isn't it? It's bound to transferrin. And then iron homeostasis is regulated strictly at the level of intestinal absorption and release from intestinal macrophages.
True.
True, good. Heme dietary sources have higher bioavailability than non-heme sources.
True.
True, good. Sorry. Ferric is better absorbed than ferrous.
False.
False. Yeah, ferrous is better absorbed than ferric. High hepcidin levels increase iron absorption from the gut.
False.
False. True. It's the other way. It has a negative feedback. Transferrin saturation is reduced in ineffective erythropoiesis.
True.
So what happens in ineffective, now what we mean by ineffective erythropoiesis is conditions like thalassemias, sickle cell anemias, where the red cells are either not properly produced or they're destroyed. There's a problem in the hemoglobin that is produced. So when that happens, the red cells are destroyed much more than in a normal person. So what happens to the iron? What happens to the amount of iron? It increases. So what should happen to the transferrin saturation? Yes, so it should increase. So that's basically false. So you have already learned all this, right? Iron, it's mostly present in ferric form, which is converted to ferrous by this duodenal cytochrome B, and it's taken into the enterocytes by divalent metal transporters, and it goes into the cell and it's transported through this carrier protein called ferroprotein across the basolateral membrane, and then it's converted by hephaestine into ferric, and then it's bound to transport proteins and transported to the liver and other sites. And hepcidin, which is primarily produced by the liver, has a negative feedback on the expression of ferroprotein and even DMT expression, right? So this is again basically the same thing, a different diagram. And so some of the iron can be stored in the enterocytes, so the macrophages as well, and once it's shed, it's removed from the body. And this is to show that only a small amount of iron is either absorbed or shed from the body every day. There's about 3 milligrams that's bound and transported as bound to plasma transferrin, right? And you have about another 300 in muscles and other proteins. You have a certain amount in bone marrow, and how it's lost is through different forms: sloughed mucosal cells, desquamation, and through menstruation, etc. And about 1 gram in a healthy male, and less than that in a woman, is stored in the liver as yeah. So that's what basically happens. That's the basic iron metabolism, which you have already learned, but I have just recapitulated. So sources of iron, you know that there's heme iron and non-heme iron. Heme iron is better absorbed than non-heme iron, and only about less than 10% of non-heme iron is absorbed from the mucosal cells. So heme iron is less affected by other dietary components as opposed to non-heme iron, and there are different sources. And now a lot of the cereals, etc., are fortified, and that can give about 100% of the daily requirement if consumed in adequate amounts, right? And there are a lot of, you would have already learned all this, right? So again, to check, this is for you to refresh your knowledge. What are the factors that would, the question is, that would reduce the bioavailability of dietary iron out of these? High calcium in diet, what would that do?
It will compete with the receptors for absorbing calcium, iron.
Yes, so that will reduce the bioavailability. Ascorbic acid?
Increase.
It Increases it. Polyphenols in tea.
Decreases.
Yeah, true. Phytates in bran, etc. Decrease. Good. Soy proteins. It also decreases it, right? So this is important for you to know even in therapy, which we will come to later on. So this table summarizes the different factors that affect bioavailability of heme and non-heme iron. Right. So coming on to the daily requirement and the required dietary allowances, in a average adult who's non-pregnant, from 18 to 50, it's about 8 milligrams for a male and 18 milligrams for a female because of menstruation. And after menopause, again, it becomes equal among males and females, 8 milligrams per day. But in pregnancy, this amount almost kind of doubles and becomes about 27 milligrams, and lactation, again, it's about half. Okay, so we'll start off to talk about iron therapy. We'll start off with a case study. So it's a 38-year-old woman who presented complaining of symptoms of anemia like shortness of breath, exertion, lethargy, and she didn't have any other system involvement to suggest any other cause that could have accounted for her symptoms, but she was found to be pale and she complained of a history of menorrhagia. And there were no other findings, positive findings in her examination. And what can you see in her full blood count? Her hemoglobin is low, and the MCV, it's in the lower side. Red cell distribution width is in the higher side. MCH is also in the lower range. And the platelet count? There is a
High.
yeah, yes, that is high. So when there is, because she is bleeding, right, there is a reactionary thrombocytosis. And then you do the blood picture, right? So you do the blood picture, you find these hypochromic microcytic cells, and you find a number of target cells and other pencil-shaped cells and other different sizes and different shapes of cells. So you do the serum iron studies and you find the iron is low, transferrin saturation is low, and serum ferritin is low. So what's your diagnosis?
Iron deficiency anemia.
Yeah, so the complete diagnosis would be it's an iron deficiency anemia, probably due to the excessive menstrual blood loss. So what would you do next? Anyone?
Test with oral ferrous sulfate, even the symptoms.
Sorry? I'm sorry, the line was not clear. Could you repeat that, please?
Give her about oral ferrous sulfate, if the symptoms disappearing.
Okay, yeah. So you would, because you will have to treat her, right? First of all, you will, now you have come to a reasonable diagnosis, you establish a diagnosis, but there is a underlying cause in her, right? So you will have to identify it and correct it. And then at the same time, you will also have to correct the deficiency. And when you're correcting the deficiency, you will have to decide on how urgent is it, right? Do we need to correct it very quickly, or can we take a few weeks to a few months to correct it? And if she's very symptomatic, and if she has other problems like heart failure that is precipitated by the anemia, then we might even have to go for red cell transfusion instead of waiting. Even if you give iron therapy, it will take a few weeks for it to correct. So if she's very symptomatic or has other problems that are life-threatening, she might even need a red cell transfusion. And when you're correcting the deficiency, you will have to decide on what route should we use, what are the other therapeutic options that you have, and decide on the duration of therapy, and you will have to follow up for response. Right. So this is again, I think, something that you have already learned. Urgency of correction. If it's asymptomatic, it's an incidental finding or slowly developing symptoms, you can correct over weeks. But if it's severe anemia or there are neurological findings, as in the case of B12 deficiency, you will have to intervene more urgently. If the person was pregnant or an infant, again, would need more urgent intervention. Then design the route of administration. Usually, oral route is suitable for nearly all patients, but if there's impaired absorption, you might have to consider parenteral route. And if it's severe symptomatic anemia, again, you might have to consider parenteral route. And when you're initiating therapy, this should be the preparation. This cage has to be corrected. Deciding on the preparation, right? It'll depend. This has to be the preparation would have to be based on the route. What are the preparations available for oral or IV, OIM, and the availability, cost, and the affordability, and other patient factors should also be taken into consideration. And the duration of therapy, it depends on the cause and the actual underlying diagnosis. So iron therapy, usually you continue till the iron stores normalize. And vitamin B12 deficiency, quite often you have to give it lifelong, depending on the cause. Folate deficiency, about 4 months would be enough to correct it. And usually, people who consume a normal diet actually don't develop folate deficiency. And once you correct it, it should be enough. So, indications for treatment, when it comes to indications for iron therapy, all patients with iron deficiency anemia, so if their hemoglobin is low, found to have iron deficiency, with or without symptoms, we should correct it, right, if there are no contraindications. And most patients with iron deficiency without anemia, depending on the etiology and the severity of deficiency. Why do we correct even without symptoms, even without overt anemia? Because if you let it progress, they can develop symptoms and they can even develop organ damage or ischemia, right? And unless adequate iron stores are replenished, this is not going to correct on its own. So we do this except in situations where we deplete iron purposefully for therapeutic purposes, like in polycythemia vera, right? To control the disease, we keep the iron stores low. In those kind of situations, we don't go and treat them, but in other situations, if there's a deficiency, we should think of correcting it. Right. So in this patient, so you said that you will consider starting ferrous sulfate, right? So oral iron therapy was started, ferrous sulfate. I thought that we could give 200 milligrams 3 times a day. And most importantly, she was referred to a gynecologist for evaluation of treatment of menorrhagia. Now, when it comes to oral iron preparations, there are 3 main preparations. You have ferrous fumarate, ferrous gluconate, and ferrous sulfate. Ferrous sulfate, this dried ferrous sulfate, is what is registered with the NMRA, right? Ferrous fumarate and gluconate, themselves are not available, but there is ferrous fumarate and gluconate in combination with other vitamins and minerals. So what we have is mostly ferrous sulfate. So when you look at the amount of iron salt, the elemental iron present in it differs. In ferrous sulfate, 200 milligrams contains about 65 milligrams of elemental iron. And there are different dosage forms. You have the immediate release tablets and you have the modified release tablets. And modified release tablets can be given once daily, but what it does is that it releases the iron quite slowly, right? And it can pass from the duodenum to the jejunum, etc. And because it releases the iron slowly, the incidence of side effects are also low. But on the other hand, only a small amount, the absorption may also be impaired because it releases a small amount of iron, and it might be releasing iron even in parts of the gut where it's not absorbed properly. And then we have the oral solutions of these different preparations. The advantage of oral solutions is that the dose can be adjusted. Ferrous sulfate, you have the 200 milligram tablet, but you can't be breaking it, etc. So you have to use that 200 milligrams. But if you're using an oral solution, you can adjust, you can calculate and adjust the dose, unlike in a tablet or a capsule. In addition to that, so as I told you, there are compound preparations. We have ferrous sulfate with ascorbic acid, we have ferrous sulfate with folic acid, and ferrous fumarate folic acid. And here you need to know that folic acid, amount of folic acid present in these preparations are not enough to be used for prophylaxis of neural tube defects in pregnancy, right? They are present in only small amount. So that is just something that you need to know if you're using these compound preparations, but these compound preparations are also available. So oral iron is the most cost-effective one available, and it's available even in resource poor settings. And when you use oral iron, it will avoid the need for any IV access, it will avoid the need for IV infusions, and avoid the need for monitoring. So administration is much, much easier and much, much inexpensive compared to IV iron. And it also, so because of that, it eliminates the potential for any infusion reactions or anaphylaxis or allergies. And oral supplements can also be used in infants, children's, and adolescents as well, right? So these are the advantages of oral iron. So usually what's recommended is giving about 100 to 200 milligrams of elemental iron per day. So if you give 200 milligrams of ferrous sulfate 3 times a day, you will get about 195 milligrams. And quite often we administer this with either something like orange juice or ascorbic acid tablets, vitamin C tablets, to increase the absorption. Okay, so you start treatment, right? And then within a few days, she comes back and she says that she has flatulence, she feels bloated, and she has developed diarrhea, and her stools are quite dark and tarry. So what do you think has happened? What could be the reason for this?
Side effects of the oral therapy?
Yes, so these are very common side effects of oral iron, right? So gastrointestinal side effects are extremely common. So you get metallic taste in the mouth, there's nausea, there's flatulence, there's constipation, diarrhea, they can get epigastric burning and vomiting, right? And stools can turn black or green, or with diarrhea, they can become tarry, right? And it can be quite distressing for the patients. They might even think that they're bleeding. So these are things that you need to advise patients on beforehand. Tell them that these problems can occur. So because of that, we need to be careful, and we need to now what is the problem with side effects? It's that if they develop side effects, their adherence to therapy will also go down. So we need to look at how to minimize these side effects and improve tolerability. So one way of doing it is to increase the interval, increase the gap between the doses. So recently it has been found that even if you give iron every other day, right, the absorption might be equivalent or even better, and the patients will have fewer side effects as opposed to giving daily dosing. right? So if they can't tolerate daily dosing, you can give every other day and try that and see. Then the other thing is to do dietary modifications. So although iron is better absorbed if taken on an empty stomach, if they can't tolerate it, we can ask them to take it with food or some milk. But the absorption will be affected, but still the tolerability will be improved. And then you can switch the formulations and switch to a formulation that has a lower elemental iron. And the other thing is to switch from a tablet to a liquid, where it might be easier to titrate the dose. So if all these fail, if they still can't tolerate oral iron, finally we might have to switch to IV iron, right? If they can't tolerate it at all. So then you switch to every other day dosing. You give it Monday, Wednesday, Tuesday, Friday. You reduce the dose a little bit as well to 200 BD, and you get her down to clinic to see in 4 weeks with another full blood count, and still the hemoglobin is 9. So it has gone from 8.9 to 9. What do you think about it? Are you happy about it? Are you satisfied?
No, it should have increased by 2 grams per deciliter.
Yes. So by 4 weeks, right, it should have increased by 2 grams per deciliter. So when we look at the typical response to therapy, usually this pica and all disappears almost, almost as soon as you start therapy, right? Within a few days, this pica and things should disappear. And then the patients will feel better. Their fatigue will resolve. They'll feel better within a few days of starting treatment. And if you do by about 2 weeks, 10 to 14 days, if you do a full blood count and do a blood picture and see, you will see a reticulocytosis. There will be more reticulocytes appearing in the blood. Right? But in mild anemias, you might not see this, but moderate to severe anemia, you will see this reticulocytosis. The hemoglobin will start to rise slowly, and it will begin after about 1 to 2 weeks. But within 3 to 4 weeks, right, there should be about a 2 grams per deciliter rise. So this patient should have achieved at least 10 to 10.5 odd HB after 4 weeks. And the hemoglobin level should return to normal by about 6 to 8 weeks. And after that, there'll be a continuous improvement in the serum ferritin and transferrin saturation, right? Over about the next 3 months, there'll be an improvement of it. So what are the possible causes for a lack or an inadequate response in this patient? What do you think could have happened?
Poor adherence to the therapy.
Very good. So the patient maybe has not adhered well to therapy. That's one of the first things that you will have to check. Or else the absorption of iron may not have been good enough. Maybe they were taking it, having it with tea, or having too much of bran, or something like that, or taking it with calcium supplements, right? Or else the blood loss, her menorrhagia was not corrected, and the blood loss was in excess to her actual iron intake. Or maybe a diagnosis was incorrect. Or else she has an additional diagnosis. It's not just an iron deficiency anemia. Maybe there is something else that's contributing to her anemia. Or on the other hand, there could be some intestinal problem, right, or an inflammatory state that is inhibiting iron absorption and interfering with iron regulation. So if there is no adequate response by about 4 weeks, you will have to think of all this and go back and evaluate and see. So this is one of the situations in which you can go for parenteral therapy if the adherence is good and still there's no adequate response. So unsuccessful oral therapy, either due to poor adherence or other problems, you can consider parenteral therapy. Or else, if you if you're to replete the iron stores with oral therapy, it will take you a longer period. It will take you about at least 3 months to do it. But if you want to replete it more quickly than that, you can consider IV therapy. Or if there is an ongoing blood loss that exceeds the capacity for oral iron to meet the needs. Or if there are problems in absorption, like anatomical or physiological conditions that prevent absorption from the gut, or coexisting inflammatory states that interferes with homeostasis, you can consider going for parenteral therapy. And there are different preparations of parenteral iron available. You have iron dextran. There was a preparation that was a high molecular weight iron dextran, but it had a lot of side effects, including a higher incidence of anaphylaxis. So because of that, now this high molecular weight iron dextran is no longer in use, and what we have is a low molecular weight, which has a better tolerability and a better side effect profile. And we have ferric gluconate, ferric carboxymaltase, then we have this iron isomaltodexide and iron sucrose. The elemental iron concentration differs between the different preparations, and the dose and the dosing frequency is also different. So how do we decide on what to give? It is again the same principle that you apply for any other drug, depending on the cost, the availability, and what's feasible, right? So when we are giving parenteral iron, we need to, because it comes as a solution, right? We'll have to calculate the dose. And when we are calculating the dose, we need to know the patient's hemoglobin. We need to know the target hemoglobin, right? We need to know the patient's body weight and make an estimate of how much of iron is needed to replenish the stores. So in a male, that's about 1 gram should be there already, but you make an estimate depending on the iron studies. You make an estimate and think. So the volume of product needed would be the iron deficit that you calculate divided by the elemental iron concentration in the product, right? So this is just for interest's sake. You need not calculate this, but practically when you're giving it, you will have to make a rough estimate and give iron, right? So intravenous iron has side effects. It could be allergic reactions like anaphylaxis, pruritus, rash, or there could be non-allergic reactions. Non-allergic reactions are usually self-limiting. They can develop fever, urticaria, palpitations. There's something called the Fishbane reaction, in which they develop flushing and things like that. This is related to how quickly you transfuse, right? How quickly the infusion goes. This is related to the rate of infusion, right? The Fishbane reaction. And it has also been reported that in patients with inflammatory arthritis, like rheumatoid arthritis, they can develop a flare, right? So usually we need not pre-medicate for anybody who doesn't have any history of allergies, etc. But if a person has asthma or multiple drug allergies, it's always good to pre-medicate with a steroid like hydrocortisone 200 milligrams before the infusion, about 30 minutes before the infusion, to prevent any allergic reactions when you're giving IV iron. Okay, so this table summarizes what we discussed so far, the advantages and the disadvantages of oral and IV iron. You can leisurely go through it and see it. We have already discussed it, but this is just a summary. Okay, so the same patient you see after about 3 months, and her hemoglobin has now come to target 13. When you look and you do the iron studies, serum iron, serum iron has improved a bit, right? Transferrin saturation has improved a bit, and ferritin is still on the low side. So how long should you continue therapy? Now, so what you need to remember is that IV iron can replenish the stores, right, quicker than with oral iron, but it will not produce a faster HB response, right? But after HB normalizes, you will have to continue treatment again for another 3 months or so to replenish the stores. So how do you know that you have replenished the stores? Is you test the iron studies again, and you see whether the ferritin level and the transferrin saturation has come to normal. And it will usually take about 3 months for this to happen. So you have to tell the patient, even if your hemoglobin is normal, we need to continue treatment to replenish the stores. Okay, so that is about iron therapy. So for the other parts, let's go through another case history. This is a young man, right, with inflammatory bowel disease. You have done the GI module, right? Have you completed the GI module?
No, madam.
Okay. So inflammatory bowel disease is there are different types. There are 2 different types mainly, but what happens is that they develop, it's a gut problem where they can have recurrent diarrheas and problems in absorption. So this patient comes with anemia. Hemoglobin is 7.9 and he has a macrocytosis, right? So you do the blood picture, you see this macrocytes, right, and different shapes of cells, and you see this hyper segmented neutrophils. So what's the diagnosis? When we do get hyper segmented neutrophils with macrocytes?
B12 deficiency, megaloblastic anemia.
Yes, so there is a megaloblastic anemia. And the causes for megaloblastic anemia?
B12 deficiency.
Yeah, B12 deficiency in combination or alone as with folate deficiency. Right? So this is just to recapitulate your knowledge on vitamin B12 and folate. So plant food products are a major source of dietary vitamin B12.
False.
False. It's mainly animal. It is absorbed from the gastric mucosa. Yeah, true or false?
False.
False. It's from the terminal ileum. So the gastric stomach secretes the intrinsic factor to which it binds to. But yeah, transported in blood bound to transcobalamine.
True.
That's true. Sorry, this also a bit. It is taken up by cells in the body by receptor-mediated endocytosis. True. Approximately half of body vitamin B12 is stored in the liver.
False.
It's true, but half is in the liver. Intracellular vitamin D is converted. B12 is converted into adenosylcobalamin or methylcobalamin. Yeah, that's also true, right? It's involved in DNA synthesis, so it's a water-soluble vitamin that's involved in vitamin DNA synthesis. It's important for the functioning of the nervous system and formation of red blood cells. We can't synthesize vitamin B12, and there are mainly animal sources are the dietary source of vitamin B12. So you get vitamin B12 from food, and the gastric parietal cells secrete intrinsic factor, and you have this carrier protein to which it's bound to, right? And it so from the saliva you have the carrier protein to which it binds to, and it comes to the stomach And from the pancreas, these pancreatic proteases degrade this carrier protein, and then after that it's bound to intrinsic factor and absorbed from the terminal ileum through these receptors. And in the blood, it's transported bound to transcobalamin and taken up by endocytosis into cells. And inside the cells, it's converted into either adenosylcobalamin or methylcobalamin, and it's involved in these enzymatic transactions. So coming on to folate, right? Infants have a higher daily requirement of folate than pregnant women. So that's actually false, right? Because the infants per se, the requirement is much, much less than a pregnant woman. Folate is absorbed from the duodenum.
True.
False.
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 Jejunum, right?
False, it's from the jejunum, yes. Folate absorption is predominantly carrier mediated. It is predominantly carrier mediated. Passive absorption of folate does not occur.
False. A small
False.
amount.
Yeah, it's false. So it's predominantly carrier mediated, but passive absorption does occur. L5-methyl tetrahydrofolate is rapidly cleared by hepatocytes. That's also true, right? So that is the final reduced product. So that's rapidly cleared by hepatitis. So that's again a water-soluble vitamin. It's reduced to its biologically active form. That's a tetrahydrofolate. Is a biologically active form. Again, it's involved in DNA synthesis, and there are a lot of animal sources for folate, right? So it's involved in this folate cycle, and B12 is also involved in this methionine cycle, right, in the formation of DNA. So now the diagnosis of our second case is megaloblastic anemia. So how would you manage this patient now? What would you give?
IM B12 or oral B12 and with folate.
Okay, so yeah, so you need to give B12 plus folate. Unless you know that there is no B12 deficiency, you don't give folate alone. So I thought that we could give this patient IM hydroxycobalamin, right, given 3 times a week for 2 weeks, and then to convert it to every 2-month doses. And because this patient anyway has this inflammatory bowel disease, bowel problem, I would most probably have to continue these injections for a long time, preferably lifelong. So along with that, folic acid, 5 milligrams daily for about 4 to 6 months was also started. Now, vitamin B12, we have 2 preparations. We have the cyanocobalamin and the hydroxycobalamin. When you look at the pharmacokinetics, cyanocobalamin is cleared much faster than hydroxycobalamin from the body. So cyanocobalamin needs more frequent maintenance doses. So what you do is you give either every other day doses, or like 3 times a week doses, or weekly doses, and then you put on a maintenance dose. So for cyanocobalamin, you need about monthly maintenance doses. Hydroxycobalamin, these maintenance doses could be given 2 to 3 monthly. The dosage form, cyanocobalamin tablets are available, but hydroxycobalamin, there's no oral form. So there's only a solution for injection or a powder for injection. And the preferred route is intramuscularly if you're giving it parenterally, but cyanocobalamin tablets, of course, it's by mouth. So treatment, hydroxycobalamin is the treatment of choice because it's retained longer. It's given IM 3 times per week, followed by 1 milligram every 3 months or every 2 months. And the side effects, the common ones are like headache, dizziness, etc. Injection site reactions can also occur, but very rarely there can be other serious problems like hypokalemia and thrombocytosis. Cyanocobalamin, orally if you're giving it, that's about 50 to 150 micrograms per day, right? If it's IM, 1 milligram every 2 to 3 days, given for about 10 injections, and then maintenance every month. So yeah, that's the same slide again. Coming on to folic acid, there are different indications for folic acid. You can give it for the treatment of folic acid, folate deficient megaloblastic anemia. So in that case, you will need to treat for about 4 months. But it's given for prophylaxis of folate deficient anemia in chronic hemolytic states or when in patients who are on dialysis or for malabsorption. And in pregnancy, why do we give folate? It's anemia is one thing, and the other thing is to prevent neural tube defects. So the dose is a little higher for this. And we also use folate to prevent side effects caused by this drug called methotrexate, which is an antifolate, right, which interferes with conversion of folate into tetrahydrofolate. So, and folate should never be used in undiagnosed megaloblastic anemia unless you know that the B12 levels are normal, or if B12 is being given, we should administer folate, right, alone. So why? If you give in a patient who is deficient in both folate and B12, if you just give folate, even the available B12 in the body will be used up. So that will push them, that will make their B12 deficiency worse. And that will lead to precipitation of other problems, other things like neuropathy and other complications of B12 deficiency will occur. Right? So it should not be used alone unless you know that the B12 levels are normal. Right. So for megaloblastic anemia in adults or children over 1 year, you can give 5 milligram daily. Go up to 15 milligrams if required, especially in malabsorption states. To prevent neural tube defects, if it's a low-risk female, 500 micrograms is enough. But if it's a high-risk female, if it's a person who has other risk factors, you need to give 5 milligrams daily. Okay, so that is all about iron therapy, B12 and folate therapy, right? We are now coming on to the other part of the lecture. So let's start that again with the case history. It's a patient with end-stage renal failure who is on hemodialysis, and he is also found to have this anemia and hemoglobin of 7 and complains of all these symptoms of anemia. So now, and you do the iron studies are found to be normal, and it looks like a normocytic normochromic anemia. Then how would you manage this patient? Any thoughts on what could be causing this anemia?
Erythropoietin deficiency.
Sorry?
Erythropoietin deficiency.
Yeah. So in patients with end-stage renal failure, there are other conditions in which there can be deficiency of erythropoietin. So in that case, if you know that the iron studies are normal and there's no other nutritional deficiency in a patient like this, you can start erythropoietin. So after that, we can start what we call epoetin alpha, given intravenously, right, about 3 times a week with his hemodialysis. So erythropoietin, you know, is made in the kidney and a little bit is made in the liver, and it is what stimulates the bone marrow to increase red blood cell production. And epoetin is recombinant human erythropoietins. And its therapeutic uses are it's used in anemia due to chronic kidney disease, and zidovudine, which is an antiretroviral drug given for HIV patients, can cause anemia, so it's used to prevent that. It's used to treat anemia related to cancer therapy, and in patients in whom you need autologous blood transfusion. You take blood from that patient and transfuse to him during a procedure to that same patient. So in them, you can give erythropoietin beforehand to increase the red blood cell production. And in patients who are undergoing elective non-cardiac surgeries or non-cardiovascular surgeries, in whom you expect to have a blood loss, you can give them erythropoietin beforehand to increase their red cell mass, so that even if they lose some blood during the surgery, they would not be needing a allogenic blood transfusion. There are problems in giving allogenic blood transfusions, like production of antibodies. So if you can avoid blood transfusions as much as possible, it's good. So in certain cases, you can give erythropoietin before surgery and increase the red blood cell mass, so that even if they lose some blood, you would not have to transfuse blood. Okay, so these are the indications of erythropoietins. So epoietins, there are different preparations. We have this epoetin alpha. What's given on the other side are these few trade names. You have epoetin alpha, epoetin beta, DABA epoetin alpha, you have epoetin zeta, right? And there are different formulations of epoetin. Again, how would you select what to give? Depends on the availability, cost, and what's more feasible. Adverse effects, commonly they can cause things like arthralgias, headaches. They can develop a little bit of runny nose and develop an influenza-like illness. Skin reactions can occur. And especially in dialysis patients on dialysis, the shunt can undergo thrombosis. Hypertension is also quite common. About 30 to 35% can develop it, and it's dose dependent, right? It can occur during the first few months of treatment, especially. Then uncommon things, it can increase the potassium levels, seizures, can cause anaphylactoid reactions, and very rarely it can even lead to pure red cell aplasia. That is, what happens is you see them responding, you start them on erythropoietin, you see them responding, you see the hemoglobin going up, but suddenly either that response stops, or they go the other way around, or the hemoglobin suddenly starts to drop again, right? In that case, you need to suspect this pure red cell aplasia. That is where the bone marrow stops producing red cells. That's a very rare side effect, but it can occur. Okay, so those are the drugs that we use to treat anemia. So the final thing is about this iron overload. And I thought we'll start off with the case history in that as well. So it's a patient. It's a patient who has been diagnosed with thalassemia major, a young boy who has been found to need recurrent transfusions to maintain his hemoglobin. And when you do his ferritin level, it's very high, 1100. So what does this high ferritin indicate? It means that the patient has actually got iron overload, right? So how do we correct it? We give iron chelation therapy, right? So iron chelators are used to remove excess iron. In patients who are transfusion dependent, for example, people who need recurrent transfusions, their red cells are destroyed much more quickly than in normal adults, right? So they need recurrent transfusion. The red cells are destroyed. The iron gets deposited in the body. So over time, they develop iron overload. For example, in thalassemia patients, in myelodysplastic syndrome, sickle cell anemias, they can develop iron overload. The other thing is hemochromatosis, that is an inherited disorder where there is a dysregulation of iron homeostasis, and they over time they also get iron overloaded. In hemochromatosis, if the patient is unstable, for example, if they have cardiac involvement and become unstable, again we can use iron chelators. Because iron deposition in tissues, it could be in the heart, the joints, right, the brain, the pancreas, will lead to clinical manifestations. You can go and read about, if you're interested, you can read about what these clinical manifestations are. So the drugs that are available, we have desferrioxamine, which is a parenteral preparation. Deferricerox and deferiprone are oral. Deferiprone, it's actually lower cost, right, than the other two. So it's much more affordable for patients. So desferrioxamine is given as a subcutaneous infusion when you're treating iron overload. So this is also used in iron overdose, right, in poisoning as well. But in that case, you can even give it intravenously, but they need much more closer monitoring. If it's simply for iron overload, you give it as subcutaneous infusion. And these infusions are given over long hours, right? 8 to 12 hours, about 3 times to 4 times or 5 times a week, depending on how bad the iron overload is. So these children, now a lot of them would be children, especially thalassemic patients, will have the subcutaneous infusion pump connected to their tummies as they sleep, right? So what happens is when they're kids, they will comply with this because the parents are doing it. They have no other choice. But when they become older, they will flatly refuse these subcutaneous infusions. So they can develop complications of iron overload over time. So it's a bit of a hassle, but it's quite life-saving for them to prevent iron overload. And it can also be given at the time of blood transfusions, but it should not be given along the same line. But if it's given intravenously, same cannula is okay. And if you give ascorbic acid or vitamin C along with desferrioxamine, it will enhance the iron excretion. Adverse effects for oral ones like deferiprone, constipation, diarrhea, headaches, reactions, vomiting, right, are kind of common ones. Rarely they can develop optic neuritis, right, and rarely kidney disease and hair loss. Parenteral ones, problems like joint pains, right, bone disorders, fever, growth retardation, skin reactions are quite common. Uncommonly, they can get problems in hearing. Hearing impairment can occur. Very rarely, they can develop anaphylaxis or other blood disorders, right? Like dropping of WBC count, platelet counts, etc. They can develop again visual disturbances. Nervous system disorders are also rare in these patients. So with that knowledge, so for this patient, we have started on desferrioxamine subcutaneous infusions given at 40 milligrams per kg per day, right? 3 days per week. So once you start this, can you think of how this patient should be monitored? Yeah, any thoughts? How would you usually monitor for therapy?
check for serum ferritin levels?
Yeah, you can monitor the response with serum ferritin level. So that is the response to therapy. What else should you monitor for?
Any adverse effects?
Right. So very good. So what are the adverse effects now you would think of when monitoring? You know the adverse effects now. Yes, you know the adverse effects. So can you think of what you should monitor for?
Anthropometric stuff. It
Yes.
is high.
Yes, so you need to monitor for the growth, right?
GI symptoms, optic neuritis.
Yes, so you need to get an ophthalmic evaluation and advise now children may not really complain of this, but you have to advise the patient, the parents as well, right, on how they should be vigilant if if they think that the child is not seeing properly, and the kids, if they are old enough, tell them that they need to uh, report if they can't see or if they're having any visual disturbance, but you need to get a basic ophthalmic evaluation and at least every 6 months to annually they need to be evaluated by an ophthalmologist. Good. Anything else?
Kidney function.
Sorry?
Kidney function.
Yes. So creatinine, blood urea, and urine, UFR and urine protein should be monitored at least every 3 months for patients on desferrioxamine. Good. Anything else? Yeah, apart from that,
Blood
prior to,
monitoring?
sorry?
Blood count?
Yeah, blood counts should be monitored. In addition to that, liver functions should also be monitored because there can be an elevation in liver enzymes, right? So about every 3 months, if you do the liver functions, that's good. And in addition to that, before starting treatment, we should actually get a audiology assessment done, right? An audiometry done to check for hearing. And every 6 months or to 1 year, you need to get a formal evaluation of hearing also done, right? And if because if you detect it early, it can be reversed by altering treatment or taking the corrective measures. Okay, right. So we have looked at, uh, we have sort of briefly gone through the metabolism of iron, vitamin B12, and folate, looked at the different preparations, indications, side effects, and the uses, looked at erythropoietin and the uses, and we have finally discussed about iron chelators. Right, so that's about it. Do you have any questions before we wrap up? Okay, so I hope that I didn't lull you all to sleep after a heavy lunch. Then we'll conclude the lecture.
Thank you, madam.